Good morning,
Good morning, sir. Dr. Bhalerao here.
sir. Nice to talk to you. How are you?
Yes, sir.
Nice
Very fine, sir.
presentation.
Very fine.
Very nice presentation you had
Thank you, sir.
out of your experience.
So it was all your experience, sir.
Thank you, sir. So, what an amazing, event going on, and I'm indebted to our dear friend Dr. Mubarak Khan for um, arranging this event, inviting me, and what an kind of academics going on. It's benefiting everybody. Mubarak is one who is single-handedly who has taken this task of endoscopic ear surgery to a different level, and he has put in a lot of efforts over the years. We all know, not only by educating doctors, but has invented lot many equipments, especially for the comfort of endoscopic ear surgeons to you know do more and more with more comfort, and given a new dimension, new approaches, on new indications, applications. So that is how we all are grateful to Mubarak for giving all this to the community. Thank you. And thank you, Sapna, for arranging everything so tirelessly. Yes, she has been, you know, pivotal in endoscopic ear surgery workshops. Her work is amazing. And this time again, we are all together because of their efforts. Thank you so much. So I missed yesterday's session. Met our dear friends. I came late night, Dr. Sachin Patil sir, and so many. And what an amazing day to begin with. Some good lectures. So, are you getting something on the screen?
We can see you, sir. Yeah, now we can see the CT scan. Yeah.
CT scan now?
I think we
Yes.
can take out that PIP, that audience.
Okay. Can you bring it to main screen now? So,
Take
our
only the
first
CT
case
scan.
to begin with. So, our first case to begin with is a 37-year-old male having bilateral hearing loss. On tuning fork, Rini negative, Weber's lateralized to the left, audiogram showing moderately severe conductive hearing loss bilaterally, little more on the left side, and perfectly normal intact tympanic membrane. Most of the time, such clinical findings are good enough to reach to the correct diagnosis. And most often it is otosclerosis, we all know. By clinical means, having intact TM with conductive hearing loss, bilateral, mostly symmetrical, maybe unilateral. It may not be bilateral always, but all these corroborative findings, you know, divert us full not to damage them. Otherwise, anything can happen. Then, secondly, post-operatively, already we are giving antibiotics as a prophylactic measure. This was behind the intact TM. Absolutely, I would say, aseptic case. Since cholesteatoma was there, a lot of raw area left, we have put a free fat. We soaked in rifampicin and antibiotic to, apply all around. So nothing more is required to be done in this case. Only thing, we must get a regular follow-up. We generally get MRI done after 1 year in case any residual thing left, but as a protocol we always get done to see in MRI if any diffusion restriction kind of scenario is seen, then that is followed. If you have any suspicion of a smallest lesion, see, cholesteatoma is not growing very fast, so you have to follow that with a serial MRI and closely following up any symptom or anything. Already ear was dead, so vertigo is not expected. Already labyrinth was dead, so nothing more. So the next case is another interesting one. A diabetic patient who had symptoms of chronic discharge pain, granulations earlier, for which probably twice the ear surgery was done, and still has a pain which is increasing in the nocturnal period, absolute profound hearing loss, had recently developed facial palsy, old diabetic patient which are supposed to be immunocompromised, and this is a classical example of malignant otitis externa. So he is developing cranial nerve palsy now. So such patients are more, this is one of the most frustrating problem. Obviously this is infection, and for infection, any infection, the treatment is antibiotic, culture directed antibiotics, commonly pseudomonas directed antibiotics. But unfortunately, because of infection in the bone, where the penetration of antibiotics is poor, and because of diabetic microangiopathy, the penetration of antibiotics is poor, these patients do not respond generally in spite of the best culture directed injectable antibiotics for long. And because of the bone necrosis, bone infection, granulations, avascular areas, these become challenging, and ultimately it may spread in the surrounding region. Very often we have hundreds of case series we have operated, we have cases seen which have the infection has spread to the parapharyngeal space, even necrose the carotid artery. In 2 cases we have seen, because this is infection, it's like a diabetic gangrene many a times. It spreads commonly to the infratemporal fossa, very commonly anteriorly to the TM joint, which is likely in this case as well, involve the dura, and even can spread intracranial. So these are challenging, and the problem is immunocompromised situation, diabetics, and these poor patients remain ultimately helpless. So what we have observed is a proper workup and proper management of these cases. We can save life in majority of the patients. So what we have is the CT scan. First of all, CT scan is of hardly any value except giving some bony details. See this, there is a multiple revision. It's like a common cavity, mastoid cavity. What we see is the TM joint is eroded on this side. If you compare with the opposite side, that's a normal TM joint, and here the TM joint area is eroded and looks like infection has gone anteriorly. Then entire mastoid cavity, though there are some cells are left behind which have to be excentrated. Since there is a profound hearing loss, facial palsy, this is again a case for more aggressive management. You have to remove all infected, necrotic, whatsoever vascular areas until you get a fresh area. Remove everything whatsoever is involved. It's a matter of life. Then if you see the critical area, that's the carotid artery, that's the cochlea. Cochlea vestibule is still intact, the carotid artery intact, the bone over the carotid artery is intact, absolutely intact. Behind is the sigmoid sinus, though there is a, if you see, this is the cochlea, this is the jugular bulb, sigmoid sinus, the sigmoid plate is intact, and you see a lot of cells behind. So that is what you infer on CT scan. Then come to MRI. MRI is more informative in terms of giving you, the soft tissue involvement, the infection. Compare this side. This is T2 weighted fat suppressed MRI. Fat suppressed means fat is suppressed. So whatever enhancing area should be infection. So you can pick up the infection. Let me put a regular T2 weighted MRI. See, in a regular T2 weighted MRI of this region, in T2 weighted where the fat is enhancing, see on both sides, wherever the fat is hyper intense, see here the fat is suppressed. Now whatever hyper intense on this side is infection. So to differentiate the infection going to the soft tissue, nothing can give information than MRI. MRI is crucial. The fat suppressed MRI, wherever it is enhancing, see opposite side normal, wherever it is enhancing is all infection. See this region of the TM joint. See even the in the superficial soft tissues, everywhere it is infection, infection, infection. On this side, everywhere is infection. So it is not that every infected area had to be removed. Only those which have no blood supply, hyperintense areas still respond to antibiotics if they are not necrose or gangrenous. If they have blood supply, the future antibiotics will work once you remove the necrotic or the bad areas. So here this will show you these changes. Now still it is not giving you the correct picture of the ongoing infection. The limitation of the MRI is the present picture. What scan reveals is not informative, completely informative. So what is the best investigation to tell you about the active infection? Because even in the operated situation, when even the patient is cured, the MRI changes still do persist for long, even for months and years together. So for the ongoing active infection, we need more information from the investigation. So next are the metabolic agents like technetium, gallium. If you get a technetium, gallium scan, they give information about the active infection. They are picked up, those agents are picked up by the radioactive agents are picked up by the actively dividing cells. They can tell you active infection which is ongoing. The limitation is you can't repeat them again and again because of the cost, because of the tedious procedure and the side effects. So to know the actual infection and to follow up, the ideal investigation to us is the PET MRI. PET MRI serves all the purposes you need to know about this particular situation. PET will give you, because of the glucose activity, the areas of active infection correctly. MRI cannot tell, even if the infection is subsided, it may show hyperintense. PET will pick up only active infection by means of more glucose metabolism, and then the reagent is picked up by the PET if there is active metabolism going on. So PET will give you active infection information and the anatomical orientation as well. The radioactive agents do not give anatomical orientation. So PET will tell you exactly wherever the infection is, and the PET MRI will tell you exactly wherever the soft tissue areas are involved, because PET CT will not give details of the soft tissues. So PET MRI is the ideal investigation to pick up the diagnosis before surgery, to know the area of interest to be tackled with, and in the follow-up. The moment infection is subsided, the PET pickup is 0. So the PET MRI is ideal investigation not only for the diagnosis, for decision making, and more importantly for the follow-up. So the PET MRI is the investigation of choice. We should know where the infection is going on, so we can tackle that where the antibiotics are not working. So idea is, it is like a sort of debridement surgery. Now in otology, with a patient with a bone infection, if you leave an open cavity, then again it invites infection. Diabetes means his immunity to tackle the infection, his neutrophilic activity is compromised. That's why he's suffering. So we can't afford to lose an open cavity. Open cavity invites infection, and in diabetic it is beyond control. So once there is a profound dead ear, diabetic patient, infection is the cause, idea, and the pain because of the infection in the bone. Idea is to do a complete widespread debridement wherever it is involved, and do a complete subtotal petrojectomy and then obliteration for future prevention of infection. We have to block off all sources of infection, incoming infection to the temporal bone. Means you have to obliterate the eustachian tube, you have to do a cul-de-sac closure, you have to remove all skin and mucosa from the temporal bone wherever it is, and then obliterate with a fat and come out and create a sterile zone to prevent future infection. That's the goal in these cases, and that's how we have saved hundreds of our patients from this problem. This is the ideal treatment for such complex scenario.
Satish Jain, sir. Can you hear me?
Hello?
It's Dr. Felix here, sir. Can you hear me? Dr. Felix here. Can you hear
Yeah,
me?
Vinod. Yes, Vinod.
Yes, sir. My query is that see, from the scans, the petroclival region right side and the bone around the renal of the bone and the foramen vessel, everything is involved.
I
So will
can-
you be doing a combined intranasal procedure also?
Pardon?
Nasal procedure also.
Endonasal procedure for what?
I don't know. I think, sir, from the scans,
Yeah.
right petroclival region is also involved.
Yeah, it is hyper intense. Yes, it is showing hyper intense areas.
So will you be doing a combined intranasal procedure treatment also?
So, if you have such areas, let me show you the contrast. Put up the contrast as well. If you have necrotic areas, this is very commonly, such infection extends anteriorly to the petroclival region, to the clivus. Even we have seen even the vertebral involvement, sphenoid sinus involvement. Wherever it is, you have to remove it. Now, if it goes anteriorly to the petroclival, once you are approaching from the temporal bone and you are planning a subtotal petrojectomy, you can approach the areas from the same area. From the same temporal bone, by the various lateral skull base approaches, you can easily approach the petroclival area once you have planned obliteration. Let me show you the contrast this patient had done. Probably this is this? Where is the contrast? Can somebody connect the MRI again? The different MRI you had shown in the morning.
We can see the microaxis in the petroclival bones.
Could be. Abscesses would be seen better on contrast as non-enhancing areas. You know, you cannot say on the basis of T2 weighted MRI whether it is abscess or hyperintense mucosa. So, a contrast is necessary to rule out abscesses. Wherever is abscess, you have to remove it. No antibiotic will penetrate and will keep persistent problems. So, wherever is the infection, you have to remove all the way completely. So, once we go deal with this part of the temporal bone, we will track the infection going anteriorly anywhere. We won't mind drilling any areas involved, petroclival, proper clivus, petrous apex, anywhere. So, we have to track the infection and follow it and remove all dead areas. This is basically diabetic debridement, as simple as that. So, contrast is, I saw the contrast study in the morning with the other, your laptop. Can you connect?
It's also entering the reverse phase, intratemporal fossa.
This infratemporal fossa is commonly affected. See this? This is all affected, and once we go anteriorly to the TM joint, we will follow this area anteriorly and see wherever it is going. We have seen this necrosis involving the Eustachian tube, involving the nasopharynx, everywhere. Contrast. Where is the contrast? Contrast. I saw the contrast. Is this? No, this is not contrast. Yes, this is the contrast. Yeah, Vinod, I am putting up this to show you the contrast. ये एक भी हो जाएगा सिंगल.
Satish, some comment. Also, in our department, we have a lot of expertise in this kind of condition, and of course, the problem is the osteomyelitis.
Yes, this is osteomyelitis.
And the other problem is the swelling of the osteomyelitis, especially in the temporal mandibular joint.
Yes.
Pharyngeal space, around the pharynx, and in the clivus. In this case, if you see the CT scan,
Yes.
you can see very clearly the erosion of the clivus. So it means that are eroding the tissue. So, of course, in our behavior is the same, to remove all the bone, infected bone, as much as possible. Sometimes we are doing also infratemporal force approach.
Sir,
Just remove some soft tissue, some also reaching the pterygoid plate and muscle.
yeah.
In order to let also the pathogen in order to improve the possibility to do the treatment in the post-op.
Okay. Okay. Let
Remain in the hospital for several months because we have a protocol for kind of disease, and we can divide the two kinds of diseases. The first is the pseudomonas aeruginosus, and the second is the mycosis. That is totally different and is the worst condition in the patient. And of course, the treatment is the debridement of the bone.
फंगल इन्फेक्शन बोल रहे हैं
Can we see the CT scan enhanced view of the thylacus?
yes.
I saw the eroding the bone of the thylacus just to underline this concept, and also the tissue invading, I think, the foramen, the rotundum foramen, so running along the clavus and the skull base.
Okay. Let
We
me.
have also some cases that the infection become bilateral. Because, for example, you remove all the bone, you are treating the patient with the drugs, and after you discharge the patients without any follow-up, and the patient come back with the infection in the contralateral aspect, because the infection running from the clivus, from the right side to the left side, and one of the worst conditions is the lower cranial nerve deficit, when you have a bilateral lower cranial nerve deficit. And we saw several cases regarding the bilateral with the deficit of lower cranial nerve and hypoglossal nerves.
Yes.
And this condition is
एम्फोटेरिसन
of course, not possible to think in this way, So it's really life treatment condition that is very important to
Yes.
consider.
Thank you. Now, coming back to your point of CT scan, let me tell you, CT scan is a very, very poor way of assessing the infection in the bone. Let me tell you what is the best modality to assess whether the bone is infected. See, CT scan shows changes which could be because of remodeling of the bone, may not depict the infection correctly. Now, what is the best way to put the infection correctly? Now, see, look at the clivus, look at the various bone changes which may be normal, which may be remodeling. You cannot depict that as an infection. The best way to predict the infection in the bone is the changes in the bone marrow, and which is best seen on T1, plain T1 without contrast imaging. Normally, what you see on T1 imaging in the bone is the marrow space. If that marrow space in the T1 is replaced, if the marrow space is not seen, the marrow signals are lost, that means that bone is invaded by the infection. This is the modality to see the infection in the bone, whatever fungal infection that we would see all the time in our mucormycosis situation. Whenever the bone is invaded by the infection, the marrow signals are lost. I can give you a couple of examples of mucormycosis, how the marrow signals are assessed on T1 weighted imaging. That is the imaging to know whether the bone marrow signals are lost. Let me give you one or two examples, and that will really help everybody to assess the infections in the bone. So, can I?
But we agree about that it is necessary to have the MRI.
Yes, CT scan. CT scan is a very poor medium.
Also, one of the most important signs of the spreading of the infection. You have to consider consider both, not just one exam. Of course, the infection you can see better on the MRI, but if you have an eroding bone in the cribus, is a characteristic sign of this kind of lesion. So you have to consider.
See, what we need.
You have to consider both exams, MRI and CT scan.
Yeah. So, see, infection anywhere, we are not supposed to radically remove the infected area. Our goal is to remove only necrotic areas, number one. I am just giving you one or two examples that will really make everybody understand what is bone involvement. See this. This is another example not related to this case because we get various sequences of MRI completely. In this case, whatever MRI we got is a different one. See this. The best is, first of all, the T2 weighted fat suppress imaging, that is the ideal imaging which suppresses fat and you get, no. Maybe this one. Just to give you an example. This is very, very important. Even the radiologists are not sure whether the bone is involved, whether it is infection or just remodeling changes. Now, I am bringing two sequences together.
So this was we have to finish the case too.
Yes, 2 minutes, boss.
And then my bike with Dada dinner.
नहीं होगा. I will finish in half an hour, no problem.
To see your case, okay?
Yes, half an hour. Now see, in this scenario, this is the pterygoid process on this side, this is the pterygoid on this side. This is the marrow signal. This is plain T1 imaging. This is the marrow signal intact and this is the marrow signal lost. This is the way we must assess the bone. Whenever, see this, even in the alveolus, see the marrow signals intact means alveolus is not infiltrated. That's why in the same scenario in this case, see, it is the marrow signal which matters. If the marrow signals are lost, then one can assume that the bone is involved or need to be excentrated, need to be drilled off. As long as marrow signals are intact, we are not supposed to do anything with the bone. CT scan has practically no value to decide the bone debridement. CT scan changes could be because of chronic infection, attrition, bone turnover, could be bone remodeling and so many regions. On the basis of CT scan, we cannot take the surgical exercise. So,
And of course, we agree with you because this is mucormycosis and we have to decide about the orbit and of course it's very important. But the natural spread of the infection
yes.
you saw before is along the cracks.
So, in this case, we will follow the infection. Wherever it is, we will not leave a trace of it. If it is the area which is not where the antibiotics are not penetrating, we have to remove it. That is the goal. So, let's see wherever the infection is going, we'll track it and see it and create the most sterile zone for this patient after doing obliteration of the Eustachian tube, exonerary canal and obliterating with the fat. This is better. So this is the left ear and what you can see the meatus, the left exonerary meatus on the left side. Most of the time this surgery is done transmeatal. As of area of interest in this surgery, the posterior superior quadrant is quite well exposed with the transmeatal route. In this surgery, we raise to expose our area of interest. Exposure is a key in any surgery. So, for the posterior superior area exposure, circular knife, my first step would be to raise a tympanomeatal flap, not a very big like we do in the CSOM surgeries, it should be adequate, not very short, not very long. So this is the level of the annulus. Roughly we give incision 5 or 6 millimeter lateral to the annulus. That should be adequate enough to cover any defect we create by removal of the bone to expose our area, and it should not be too big to be cumbersome to handle. Number 2, our flap. See what I am doing? Multiple go through to go bang on the bone now. There is a horizontal, curvilinear horizontal incision. See this? Curvilinear going anteriorly. Because anteriorly I am not limiting the incision. Anteriorly I am not limiting the incision. I can further, if needed, extend in case I need to do something anteriorly, anterosuperiorly to the anterior malleolar ligament, to the malleus or anything. So I should have all the options open in case I need to change my plan and go further anteriorly. So that's a curvilinear incision. But posteriorly, I don't need to go further anywhere, we all know. So posteriorly, see, this is my horizontal incision. इसको टाइट कर दें क्या वहाँ से उधर इससे circular vertical, I mean side knife. See, that's the horizontal incision, and inferiorly, as I said, we don't need a bigger flap. We don't want to make it cumbersome to handle. I will make a release incision vertically down, a limiting incision, I would say. This incision limiting my inferior extent, and then one can raise the tympanomeatal flap again. ये 20 number, circular again. See this? I can start raising this flap with a hole in the circular knife with suction behind to prevent damaging the flap, and one can easily raise this flap. Inferiorly, I don't want to go further. Superiorly, yes. I need to keep all the options open. See now, as you go superiorly, the flap is much thicker. Can you hold this? Much thicker. See, be careful not to give unwanted tears. That is our area of interest. And keep going towards the annulus. Stay bang on the bone. At the level of the annulus, you can see something. बढ़ नहीं रहा किसका? Magnification नहीं बढ़ रहा? The magnification not working? Not working. Microscope magnification, please. Not working. Madam, hold करना. Anyway, I wanted to magnify to show you much better. Yes, this is last. Manual. कैसे? मैनुअल है क्या इधर? नहीं मैग्नीफाई थोड़ी ना होगा. एनीवे लीव इट. यो रखो टाइट. यो हाँ. यस, I can see on the monitor the picture is centered. I know I need to do myself this now. See now, just medial to the annulus, what you see is the chorda tympani. That's the chorda tympani. I can see just medial to the annulus, and I can open in between by separating the mucosa and can separate the chorda well behind. This chorda tympani is an important nerve in this setting. Unlike CSOM surgery, where most of the time chorda itself develops neuritis because of the ongoing repeated infection, but here it is normal, circular. Having elevated, just keep going behind and keep this flap off your surgical field by means of pushing and pushing this away anteriorly. Side. See the annulus. See the annulus. This way I can push my entire flap anteriorly so it doesn't bother me much. And my again focus is towards my area of interest, that is anterosuperiorly. This is anterosuperiorly, and we can see the glimpse of the incudostapedial joint. Now, as I said, exposure is the key. At this stage, we do not see too much of the ossicular chain, we do not see the oval window at all. Here, the ideal exposure should make you see complete visualization of the oval window and the stapedial arch. So, in order to expose that, you need to remove this bony overhang to the level that you should be able to see the entire foot plate and the oval window. By and large, this exposure should be to the level, superiorly to the level that you should be able to see the fallopian canal adequately, and posteriorly to the level that you should be able to see the pyramid directly, so that you get adequate space to manipulate your piston. Great. Now, इससे बड़ी है? कौन सी है? This one. Oh my God, this is funny. This will not. Now, to remove this overhang, there are many ways. Like I've been using my Karl Storz's curate for years, which is very, very sharp, though I have not brought today any instruments. You can use a micro drill, you can use a micro chisel and a hammer to remove this overhang. Give me a micro drill if possible. Because this curate will not take it so easily. So we'll expose, like I said, superiorly and posteriorly adequate to confirm our diagnosis, seeing the area of interest completely, the oval window region, and adequate space to maneuver our piston. किधर है? ये 20 नंबर से बड़ा लगा, एक साइज बड़ा चल रहा है. ये है डायमंड है ना? No, diamond. So what I will do here, we'll take a diamond burr to, as I'm missing my curate, cotton ball. My friend Ashish Bhumkar uses a and Ashim Desai as well, they use a very fine chisel and take away this entire overhang, most of the overhang in one go. And that is very, very controlled and effective. You can use whatever you are used to and should be able to use everything. दो इसको पकड़ो. See, this is our area of interest. So I will thin out this overhang to be curated better. Funny. थोड़ा ज़्यादा नहीं. Using diamond bar, never use pressure. If it is too thin, it can break and damage your ossicular chain. You have to have a patience because this bone is very, very thin afterwards. We need to leave. So you can remove more efficiently under control with the curate. The use of drill is to make the curate more effective, to make it thin. So no force on the drill at all. That is important. Curate, whatever. Needle, angle needle. Needle, angle needle. कोई भी right angle needle, any angle needle. Pick. हाँ इधर दो. You can see the glimpse of the fallopian canal above. Curate. You can see the body of the incus. We are not supposed to expose. The moment you see the broadening of the long process of incus, see the broadening of the long process transforming into the body, and that is the point where you need to expose. We are not supposed to overexpose the incus body. Otherwise, it may invite the tympanic membrane to adhere to it, and that's a disaster. Retraction. See this? We have adequate exposure of the fallopian canal. The adequate exposure of the incus, not the body. We are not supposed to expose the incudus-malleal joint or the body of the incus. Exposure doesn't mean overexposure. Now, this is the fallopian canal, the caudal canal. Can we enlarge the view? The magnification? It's not working. Can somebody help? The magnification, this is not working. This is maximum. किया मैंने, देखो ये किया. माइक्रोस्कोप को यूं है? नहीं, अपर्चर तो ठीक है. उधर से हो जाएगा जूम. Now little more posterior exposure. I can see the oval window nicely, but not the stapedial tendon. I can see the glimpse of the pyramid. Drill. drill. Now, this chorda is running through a canal here. थोड़ा क्यों रखो? This chorda is running through a canal here. थोड़ा थोड़ा. पानी डालो, थोड़ा पानी. Yes, 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 yes. Yes. Now, curate. You can see the glimpse of the pyramid below. You can see the posterior crust nicely, and you can see the complete view of the footplate behind. छोटा सा gel form देना. See everything visible, and this chorda is covered here like this. Now, 20 number दे दो suction tip, one size finer. कहाँ काटे हैं? ये लो पकड़ना, स्पेकुलम पकड़ो, डाल दो अंदर. Hold the speculum. क्या needle? Needle. यूँ रखो, यूँ. यस, ये आपका हाथ बीच में आ रहा है. यस. Yes, curate, and we'll be needing needle again. This is the periosteum of the chorda. Chorda is going inside like this. See the nice chorda needle. I can reflect the chorda little down without any problem. Like this. See the chorda is deflected down, and you can see the exposure of the area we wanted. I hope it is very well or clearly visible. I can see the entire dimension of the foot plate, the posterior one most important here. इससे पतला भी है ना section. The section tip. This is too big. इससे पतला भी है ना. हाँ है ना. Keep the finesse ready. Now, that's the exposure. What I need to do is a bypass surgery we aimed at. So first of all, let us confirm our diagnosis. Needle. So, need to check the ossicular chain. So first of all, how to? This is the malleus anteriorly. See, when I mobilize the malleus, you all can see the incus is moving. Fine. Now, let me check the movement of the foot plate. Can somebody help me with the magnification? And foot plate is fixed. See this? Even if I mobilize the arch, the foot plate is not moving. That's how the commonest diagnosis we keep in mind. This is otosclerosis. There are many connective tissue disorder which can give rise to fixation of the foot plate. Now in the recent studies it has come out that in complete stapedial fixation, the otospongeosis or the otosclerosis is responsible for less than 50%, pathologies, fixation. There are many other connective tissue disorders responsible for the fixation of the stapes. But here we are not aimed to treat the disease again. Our aim is to bypass this fixation. Now, that's the foot plate. Nice. Can you give me this thing? Give me a little. नहीं हो रहा ना, एनलार्ज नहीं हो रहा, इधर का भी करता हूँ देख. This is, and I can feel my fallopian canal pretty intact. See this? This we could all predict it because of CT scan. No, not focusing, नहीं हो रहा ना, not working. ना नीचे तो जाता, ऊपर इससे ज़्यादा नहीं जाता. This is the highest.
Difference will continue, but the lunch is ready. Those who have to go and have a quick bite can go and come back. Thank you.
Hold the picture ठीक है ना? हाँ, magnification जरूरी है. Anyway, hold this. So we have checked the ossicular fixation. Now the question is, next important steps of stapes surgery. The two crucial steps always warn us. One is the clerotomy, another is fenestration. If the foot plate is not adequately fixed, these two steps can invite disaster. An unwanted movement of the foot plate, unwanted sudden movement can bring in sensorineural hearing loss. So to avoid that, to almost certainty, we have been using for last more than 15 years now, 18 years, the laser. The laser means atraumatic. Atraumatic means non-touch technique, vaporization of the suprastructure and the foot plate without even touching it can safely remove it. Now, in case you don't have a laser, what can you do? That's a very important scenario. This, without laser, I have been doing after quite long period. So what are the options we have? The best is what Hugo Fish suggested years back, decades back, that is reverse stapedotomy. Reverse stapedotomy is what? You reverse the procedure. Means, in a regular scenario, we first disarticulate the IS joint, cut the tendon, then make the fenestra, remove the suprastructures and make the fenestra. But this goes uneventful if the foot plate is adequately fixed. In case the foot plate is not adequately fixed and your mechanical movement cannot be 100% perfect always. Even a sudden movement over pressure can lead to a floater, a fractured foot plate, submerged foot plate, or any sudden movement can lead to sensorineural hearing loss. So in order to avoid that, what best can be done? This is what I am going to demonstrate. The magnification is not going beyond this, so I cannot go beyond that. But the steps are reverse. Reverse means, in the regular situation, the last step is fenestration. Here my first step would be fenestration. Taking the help of the entire intact incudostapedial arch, so that my foot plate, even if it is not completely fixed, it is not going to get submerged. It is not going to get submerged or a floater because my arch is still fixed. So taking the advantage of the arch, in case I am not having laser, sometimes your, the anatomy is so overcrowded with a thick posterior crust, this tendon Then you can thin out the posterior crust, remove the tendon first, cut this, and you can develop more space, still taking the advantage of intact stapedial arch. So here we have adequate space. You can see the majority of the foot plate. Now the second question is where to make fenestra. Ideally, we should make fenestra, this what I am talking, out of a novel research by Hugo Fish again. Professor Hugo Fish is like a, he has been phenomenal in otology and lateral skull base, and then Professor Mario Sana, who has revolutionized the science of lateral skull base. So Professor Hugo Fish published long back, after studying almost 300 temporal bones, to see the distance between the inner surface of the foot plate and the vestibular end organs. And they found the farthest vestibular end organ from the inner surface of the foot plate is lying at the center of the foot plate inferiorly. So we should make the fenestra there to keep your piston farthest from the damage to the vestibular end organ. So my fenestra would be in the center inferiorly, always. If you are more anterior, you're likely to hit sacule, not now, even post-op if your piston excurs more and more, inside in the pressure situations. So we should keep them away. Superiorly can hit the sacule. So always keep in the center inferiorly. And here I am taking the advantage of the fixed intact intact incudostapedial arch and make the fenestra first. Chalu karo, on karo. So here I am using a skeeter, not a regular one from the Medtronic. Here I am using, speed कितनी है?
अभी actually 12.
अरे बहुत और कम करो, 2000 कर दो. Can you control? ये कितना है? नहीं कम करो ना यार, 3000 नहीं चाहिए मैं. हाँ? I can use a micro perforator. I can use a regular drill, micro drill, or use a scritter. This scritter is looking dicey. This is not from Medtronic. I am using for the first time. This is from Ban Air and had a cutting burr. Oh my God. See this? Has a cutting burr, cutting edge. Dangerous. Don't you have a regular scritter? इससे एक साइज छोटा है ना. So I have to be very, very diligent not to use any extra pressure. इस साइज क्या स्पीड कितना किया? 1000 करो उसको यार.
एक एक्सीलेटर करो सर आप. थोड़ा स्पीड जो है ना.
Okay. Accelerator.
Just like accelerator.
Okay. So I am first making the fenestra in the center of the foot plate, taking the advantage of an intact incudostapedial arch. No pressure at all. And I am through. The most common region, most important region giving rise to sensorineural loss in this setting is the suction over the fenestra. One must never suck directly over the fenestra. The suction is the region, the commonest region to give sensorineural hearing loss. Yeah. Number 2, never make the vestibule empty by any suction. Suction from side, suction directly above, anywhere the vestibule should remain full of fluid. See this? That is my fenestra and the vestibule full of fluid. If the vestibule is full of fluid, then you are very, very safe to give sensorineural hearing loss, to prevent that. Now, the next reverse step is piston placement. After the I have not disarticulated even the incudostapedial joint. I have not removed the suprastructure, not even cut the tendon. I am taking the advantage of this fixation to put a piston now. This is reverse stapedotomy. So now I will do a first a piston rehearsal because every make has a different, measuring gauge. This is, I don't know which company, this is not Kurz, this is Kurz. Kurz, this is not a clip one, this is a different piston, looking like a clip. Oh, so complex. My favorite piston is a Kurz clip piston that is easiest to use. The titanium has extreme biocompatibility. See this? And doesn't need a crimping. Crimping is hazardous sometimes. Yeah, it looks adequate. Why? The size of the piston, the length of the piston is one of the most crucial determinant of the final outcome. Particularly if it is an overlong piston, can be a disaster. Overlong piston is always a disaster. This was 4.5. I was doing a rehearsal because we don't have a measuring gauge. It looks nice. See, the piston is right into the fenestra. You can see. I will, to give it a little length, I will bring it little down. Yes. Here. Right angle hai, pick. See, so easy to use. My lower end right into the fenestra and there is a bar. Oh God, too tight. Our regular titanium clip is an amazing piston which has a sort of spring kind of an action when you push right onto the incus. So this is not the regular titanium one, the clip piston one. This requires a pressure. That could be dangerous sometime. Let me check the opening of the piston first. This I am using for the first time. Too tight. Can you see this spring? Kurz clip is a very simple piston. This is not the one. You just take in and apply it just like a video game. No complicacy. This is a very stiff opening, at the opening end. always keep an eye on the lower end. This is a simple clip titanium would have been through by now. This opening, this edge is very, very cumbersome to handle. Section. Very tight opening. Yes. Now, I cannot, you know, uh, magnify the picture, but I can see very well now. My middle slot of the piston is taking onto the incus. See this? And piston is very well inside the fenestra. My fenestra was 0.6 and this piston is 0.4. We use many a times blood to give a sort of fibrin kind of a solution. Blood contains fibrin to act like a fibrin. And this piston is very well secure right onto the incus. See this? That's the beauty. So reverse stapedotomy, first two steps have been done. Needle, straight needle. My lower end is right into the fenestra. This upper end of the piston is very, very cumbersome. I don't know why they unnecessarily complicated it. The other course piston is a very simple to maneuver. See the lower edge? Nice into the fenestra. Now next two steps, three steps rather. First, incudostapedial joint. Here is the joint, I can see. Now my piston is very well in place. See, this is too thick to separate the joint. Need a sharp one, or give a needle rather. Any angle needle. The instrument is too big. Okay, let me try this. Yeah. Separated the joint. Scissors. With laser, everything becomes so fantastic automatically, so fast. Scissors is too big. Can you have other scissors? Fine scissors. Cut the tendon, needle. And lastly, that's the suprastructure. Scissors, a section. Laser we could vaporize without even touching anywhere. With the, if my foot plate is not adequately fixed and if I remove it without fenestration and without piston placement first, would give a floater and would be impossible to do a stapage without the laser then. Here taken the advantage of the intact arch and remove the, put the piston first and remove the suprastructure. So that's a very, very important step in stapage surgery. This blood I am taking the advantage to fill the oval window. No matter how the blood is here, my vestibule is full. The blood cannot trickle inside. That's the beauty. That's why I said in the beginning, never ever suck over the oval window. The pressure inside the vestibule is much more than the pressure inside the middle ear. So blood cannot trickle inside. You see the suprastructure coming out. And before that, my stapedotomy is already done. So this is reverse. And I am so scared without the laser that I should not mobilize it. So that's the favorite technique when you don't have a laser. करा दो. See, this blood will take care of sealing the vestibule. Generally, we do a direct piston and don't put any material to seal it. Hold karna. Generally, if the piston is not over long, quickly the endosteal membrane forms and seal it without giving any problem. But yes, if your piston is too over long, can lead to a disaster. Very nice. The piston is very well inside. See this? Very nice. And I want this blood to accumulate. I have removed the suprastructure. My piston is very well secure. And we did it without laser, without, mobilizing the foot plate. And this blood is the welcome thing to fill the oval window. Now, in extreme demanding situations, we do use a vein graft. Like my friend Ashim Desai uses for every case. That has a distinct advantage, but it's not mandatory. But in demanding situations like if the patient is a, professional pilot, has to travel frequently, has to dive, in revision situations, always we don't take a chance and put a vein graft to seal the oval window, but not in the regular one and in pressure situation, demanding situations. The contraindication is the otosclerosis involving the oval window can ossify the vein graft. The biggest advantage in the regular situation, if you use the vein graft regularly, is the only advantage, what I believe, rather than sealing, it can prevent you putting a long piston. If you try to put a long piston with a vein below, it will invaginate the vein like something giving you a picture that the piston is too long. It can warn you from putting a long piston by giving a picture of vein invaginating too deep with the piston. So it can warn. Otherwise, in a regular situation, you have to be very accurate in measuring the size of the piston not to use an overlong piston. Overlong piston is a disaster. The single most important determinant of the overall outcome. Obviously, everything is important, but the single most is the size of the piston, and a long piston is a disaster. So vein can prevent you putting a long piston. That's the biggest advantage. Otherwise, in a regular situation, you don't need to use a vein if you are careful. See this? My piston is well in the fenestra and my blood is sealing all around. We sometimes use ask our anesthesiologist to draw a fraction of milliliter of the blood, and we pour over the oval window to give additional seal. We generally do not recommend using soft tissue material. That can invite granulomas sometime. See this? The flap coming back on place. Flap is long enough to cover the defect in the bone we created for exposure. And finally it is the उसमें डालो ना ये ड्रॉप में. We will put gel form. See the approximation and just put a gel form and come out. Can somebody?
हाँ सर गौरी इज देयर
Flap को मत हिलाना. So, so Dr. Gori is going to place the gel form, preparing the gel form, soaked in ciprofloxacin dexamethasone drops, antibiotic steroid drops, and that's it. So, that was a regular stapes, the reverse stapedotomy without the laser. Any questions we can undertake?
एक बार वो पेशेंट को देख लेंगे.
हेलो, थोड़ा वॉल्यूम बढ़ाओ ना इधर का.
बढ़िया हो गया.
रेगुलर लेजर नहीं आते ना,
लेजर नहीं है सर हमारे पास.
डर लगता है. हेलो हेलो हेलो, थोड़ा इधर वॉल्यूम बढ़ाओ ना इधर का. Yeah, faintly. Yes, please. Hello, I can hear you well.
Demonstration. Thank you so much. There's a big applause here in the audience.
Thank you for your attention once again.
Yeah. Please take few questions here, sir.
Yes, please.
Yes, sir. Sir, excellent surgery as always. So, Dr. Shruti here. So, while you were, what instrument did you use to break the crura? I because we didn't know. So, did you use a right angle?
Yeah, that was a right angle pick. Generally, your question is very important, valid. It is the posterior crust which is stout. And breaking the posterior crust or fracturing the posterior crust invites problem if you are not careful. Anterior crust is almost always fragile. So what we do generally, which I didn't do here, generally we make the posterior crust thin by a micro drill.
Okay, sir.
So to make it fragile, so you can easily break it with any instrument. So best is to give extra care, to stay extra careful. Always try to thin out the posterior crust before fracturing it. So that will, further lessen the chance of any floater or anything.
So, that can be done in reverse stapedotomy also.
Yeah.
That's okay.
Yeah, I found adequate space for the reverse stapedotomy, so I didn't thin out. But yes, it would have been better to thin out because there is always a chance of, floater if you don't thin it out and try to fracture. Because I was not having laser.
Yes, sir. Yes, sir. Okay, thank you, sir.
Dr. Satish.
Yes, sir.
Dr. Alok here.
Yes, boss.
Achha, it has happened to me for one time that we also do the laser stapedectomy and vaporize the posterior crura with the laser. And after that, we remove anterior crura. One case, the anterior crura was so thick,
Oh,
dislocating.
so unfortunate. So unfortunate. That's why we must focus on the CT scan. I remember Dr. A.B.R. Desai's word. Getting anterior crura thick is your bad luck. He has reported the incidence of thick anterior crura 1 in 3,000 cases. Or a thick anterior crust is a disaster unless you thin it out and fracture it. And because reaching out the anterior crust is difficult. Prediction of the thick anterior crust is difficult, but now with the CT scan you can very well predict. So if you have a CT scan and prick the thick anterior crust, either use a fiber laser to vaporize that first before fracturing it, or try to do it. To use a fiber laser or elevate a little bit of the incus, angle yourself, attack, and thin out the anterior crust. Try to thin out with the drill. If not possible, try to cut with the crurotomy scissors. So you have 3 options to do it, and the best is to predict with the CT scan. Without that, if you are not knowing and try to fracture it, it's a disaster. It is definitely going to mobilize the foot plate. So thick anterior crust is a rare 1 in 3,000 incidents, and you have to be very careful. That's why CT scan can very well predict.
And if foot plate is avulsed, the subsequent question, then what is the next best thing one can do?
So, okay, if you are given a floater, suppose, if you are not having a laser, just don't do it, put a vein graft over it and put a piston over it. It may fix over the period of time. Then you may have to revise. But yes, if you have a laser, still you can make a fenestra and do a regular stapedotomy.
Any other questions? Hello, Dr. Satish, Dr. Srinivaraman.
Yes, boss.
Suppose during manipulation of the foot plate, whole of the stapes get avulsed.
Stapes gets avulsed, yes.
This is not floater, this is total foot plate gets avulsed.
Stapes comes out completely, you mean to say?
Yes.
Yes. Then the best way is, first of all, without delay, you have to cover it. No suction over it. If gets avulsed, you have given that you cannot revert it. Take a vein graft and cover it, number 1. Number 2, in such situation, we do not advocate piston placement. We use or we advocate a cartilage. Cartilage coming from the foot plate, a Y cartilage going underneath the incus. The Y sling going underneath either side of the incus, and the lower portion right over the vein graft. Y cartilage, no piston. This is what again we learned from ABR Desai. The pressure inside the inner ear is always more than the pressure inside the middle ear, which contains just air. Inner ear contains fluid. And that pressure is so balanced in the inner ear that in a regular situation, the movement, even the fraction of the foot plate goes in, the pressure of the fluid is so tight that the fluid mobilizes and the round window comes out in a regular situation. You know, with a regular hearing, what you and me are hearing, how much the foot plate goes in and out? In nanometers. In nanometers, it goes in and out. And that is good enough to displace the fluid because the pressure of the fluid inside is high. So, if you have avulsed the foot plate and covered with a vein graft, over the period of the time, this vein graft will balloon. It will little bit balloon out because of the high pressure inside. And if you have put a piston, it is likely to perforate. Cartilage, the body's own material, very thin, it doesn't perforate at all and it works as good as always. So if you have avulsed the foot plate completely, my recommendation is not to use the piston at all over the entire oval window graft. or the thin fenestra, you can use piston. It is not going to balloon out. Rather, piston will keep it pushed in. But when the entire foot plate is out, never ever use the piston. Use a Y cartilage. Anything else?
No, actually, my question was during reverse stapedotomy, whole of the foot plate, whole of the stapes gets reversed. After putting the piston, then what to do?
After putting?
After putting the piston in reverse stapedotomy, once you are removing the stapes,
Yes.
whole of the stapes, and all the stapes gets reversed.
Yes.
Yeah,
Yeah.
seen this.
See, yes, I got your point. In that situation, you have already done your work, piston placement. If you find that the foot plate is coming out, stop and replace the foot plate and cover with a vein graft all around. You don't have to do anything else. See, this movement is very tricky. If you find that your foot plate is fracturing, coming out, that's a very, very controlled movement. Stop it and leave it. Your piston is already out in, so just cover with a vein graft and leave it. That's it.
Sir, I am Dr. Salim Medicine, HOD PRC Hospital.
Sir.
Sir, one question, sir. Continuing what the things you have told. So once while trying to fracture the superstructure, all stapes came out. And
Yeah.
as per you told that we have to put the vein graft and put the cartilage. So what is the effect on hearing, sir, on this one?
Yeah. Still hearing is very well maintained if you don't use the section over the oval window. The sudden movement definitely can invite hearing loss, but not always. We have seen patients, the complete full plate came out, didn't do any manipulation, just covered with a vein graft, put a cartilage and still give good hearing results. It is the disaster is the suction to make the vestibule dry. Never ever put a suction and make the vestibule dry. Dry vestibule is always a disaster. So even if the foot plate is avulsed, don't be in panic. Don't put any suction all around. No blood will go inside ever. As long as the vestibule is full and the pressure is high inside, no blood will go inside ever. Just cover with a vein graft without manipulation and put a piston. Still the patient can maintain good hearing.
Sir, one more, sir. Sir, last question, please.
Yeah, please.
Sir, this is my experience, sir. Instead of putting the vein graft, I put a false fascia graft over that.
Which graft?
False fascia.
Which?
False fascia.
Temporalis fascia.
Temporal fascia. False, not the main one.
Okay.
Aerial tissue, I put over the stapes foot plate area.
Yeah.
Over that one, put the piston. Post-operatively, thankfully, she got a very good hearing back, sir.
Great. And what are the long-term results?
Sir, long term, she has lost for the follow-up. I got the number, I will call her and ask.
Yes. So you have done a great job, no doubt. Our concern is the long-term ballooning of the membrane. And that's why we advocate not to use piston, because the pressure is always high in the inner ear side than the other side of the graft. Number two, why vein? There are lots of studies done, published. See, our annular ligament is unique. When the sound, let me take you a minute to understand, to just throw a light on the physiology of the hearing here. The sound strikes the tympanic membrane. Tympanic membrane mobilizes, incudomalial joint mobilize, that's the synovial joint, it glides, then the incudostapedial joint glides, and then the stapes goes in and out. And to add on to the protection there is the tendon, the stapedial tendon, and the most important protection to the inner ear, most important out of all, is the annular ligament. The annular ligament, it has been studied, So when a high sound comes, the high intensity sound comes, all these mechanisms come into action to prevent the excess sound going into the vestibule. So mechanism number one is the tympanic membrane. It contains radial and the circular fibers, and it becomes stiff. It becomes stiff over a certain pressure or sound. It becomes like a wall, doesn't transmit further, doesn't move any further. Number one. Second protection is the incudomedial joint, get fixed. Third is the incudostapedial joint. Still the sound passes. The most important protection is the annular ligament, and it has been studied. The vein graft elastic fibers are closest in architecture to the annular ligament. That's why the vein graft is the preferred material all over. This is all scientific. This is the ultra microstructural studies which have proven that the vein graft in composition of the elastic fibers is closest to the annular graft, that annular ligament. That's why the annular ligament is, used commonly. Number two, now after stapes surgery, I told you there are n number of reasons for the sensorineural hearing loss, because the entire mechanics has changed. The God's given protection is, changed. You have removed the tendon, you have bypassed the annular ligament. The biggest protection we have bypassed, that's so funny to understand. In a regular situation, a 3.2 millimeter size foot plate goes in and out and give us adequate hearing. And now the entire thing is bypassed. Only a few fraction of millimeter, 0.4 mm piston is going in and out and is still giving adequate hearing. How the mechanism has totally changed. The reason is the foot plate was normally goes a nanometer, movement in and out. It has been studied around 270 nanometer is the highest movement of the foot plate that goes in and out. Nanometer. And that's how it displaces that, because of the large surface area, the fluid adequately to give us hearing current. Now with the piston, the dynamics get changed. The piston size though is small, but the excursion is too high. The foot plate which goes 270 nanometer, the piston goes a fraction of millimeter in and out. The excursion is too high. Even the pressure situation, it can go even up to 0.5 millimeter in and out to displace the fluid. So the overall mechanics has drastically changed, we should keep in mind. And because of that, because of the protection is lost, sometimes even in the best hands, the best surgery done, or the period of time, unknowingly, for no reasons, the sensorineural loss ensues because the God's given protection is lost. The dynamics have changed. That's how we need to understand how the piston works and the foot plate works. Annular ligament works. How can you replace the annular ligament by means of a vein graft, the best material? Any questions further?
No, sir. Thank you so much, sir. It was an excellent demonstration. We are going to have two small talks, one by Dr. Mubarak, sir. So, meanwhile, the OT gets prepared. Okay, we'll shift it to the lecture series, sir. Yeah.
Okay. Thank you.